So in today's 15-minute integrated medicine series, we are going to discuss an important concept, the renin angiotensin system. Actually, the renin angiotensin aldosterone system. So many of us are familiar with this thing because we are reading it from the first year of MBBS. So I will try to concise the RAS system from physiology and we'll extend it to the clinical medicine aspect. So the name itself suggests renin, angiotensin, aldosterone. We have three main parts of this. So renin is a substance which is produced from the kidneys, specifically the afferent arterioles. That is, we have cells called juxtaglomerular cells, part of the juxtaglomerular apparatus. So this renin is produced from the JG cells of the juxtaglomerular apparatus in response to, like it is in close contact with the afferent arterioles as well as the distal convoluted tubules. So it's in contact with the JG cells are in contact with the afferent arterioles as well as the distal convoluted tubules. Why this anatomy is important is, these are sensors. So the juxtaglomerular cells can sense the blood flow coming through the afferent arterioles, and it can also sense the sodium load coming out through the distal convoluted tubules of the nephron. So we basically have three stimuli which stimulates renin from the juxtaglomerular cells. So one is the reduced blood flow or a hypotension, which is picked up from the afferent arterioles. The second stimulus is the sodium load, which is sensed through the distal convoluted tubules. Low sodium. The third stimulus unrelated to this is beta sympathetic activity. So these are the three stimuli which makes the juxtaglomerular cells secrete renin. Now what does this renin do? Angiotensin is another peptide which is secreted by the liver. The function of this renin is to convert the function of renin is it converts another peptide called angiotensinogen, which is produced by the liver, into angiotensin 1. So just remember this step, it's of academic interest only, but it's not used of clinically. So this angiotensin 1 is converted to another peptide called angiotensin 2 by an enzyme called ACE, angiotensin converting enzyme, which is produced by vascular endothelial cells of the lung. Okay, so what does this angiotensin 2 do? Angiotensin 2 has mainly four activities. So one, it causes arteriolar vasoconstriction. So you know very well, when arteriolar vasoconstriction occurs, it increases BP. So the second activity or second action is it causes sodium reabsorption by the distal convoluted tubules. This again increases BP. The third activity is it increases aldosterone secretion. So aldosterone is a hormone which is produced by the adrenal gland, specifically zona glomerulosa of the adrenal glands. So this aldosterone is produced by an enzyme called aldosterone synthase. Okay, so aldosterone synthase. What does this aldosterone do? This aldosterone in turn acts on aldosterone receptor in the collecting duct of the kidney, we have two cells in the collecting duct. One is principal cells and another is intercalated cell. It acts on the principal cells of the collecting duct and it increases the production of ENaC channels, epithelial sodium channel. This in turn increases sodium. Okay. So this is the third part of the renin angiotensin aldosterone system. So the fourth action is the same angiotensin 2 also acts in the pituitary to produce vasopressin. Vasopressin, again it causes sodium and water retention to increase BP. So these are the four main actions of angiotensin 2. Angiotensin aldosterone system. So physiologically, renin angiotensin aldosterone system is a compensatory mechanism of the body to it compensates when hypotension occurs. Renin angiotensin aldosterone system gets activated to increase BP and increase sodium reabsorption. So this is how the entire system acts. Now this finishes the normal thing which we know about the physiology. Now what happens when this becomes pathological? When this system gets increased, when there's an abnormal activation of this process, we can very well see BP will increase, sodium absorption will increase. So dysfunction or dysregulation of this renin angiotensin aldosterone system is one of the reasons causing essential hypertension. So long term, apart from this vasoconstriction, it is said that it has also deleterious effects like fibrosis of vessels, endothelial remodeling, which are not good for the body. So in fact they lead to same thing. They lead to arteriosclerosis, hypertension, heart failure and renal failure. So the same system which is doing a good by increasing BP in terms of hypotension, when it becomes dysfunctional, it leads to arteriosclerosis, hypertension and heart failure. Aldosterone is a part of the zona glomerulosa, as I already told you. So there's a disease called hyperaldosteronism. So from this chart we will understand that when hypotension is there, renin is stimulated. This renin stimulates aldosterone. But there are some conditions in which even without renin stimulation, aldosterone production increases. So something called as Conn syndrome or hyperaldosteronism. So in the same thing also, we have increased sodium retention and more of potassium excretion leading to hypokalemia plus high BP. So one of the causes of secondary hypertension is Conn syndrome. So this is what pathology. So it leads to dysfunction of the system, leads to essential hypertension. It is one of the processes causing heart failure. And we have discussed about hyperaldosteronism also. Now, when we are speaking about arterial vasoconstriction, in the glomerulus, the efferent arterioles also get constricted by the angiotensin. When this process happens, protein filtration or glomerular filtration rate increases. So when GFR increases, there will be more of protein leakage through the glomerulus. So that is why in chronic kidney disease or in long-standing hypertension or in diabetic kidney disease, when there is remodeling of the glomerulus, there will be protein leakage through the kidneys. That is picked up by microalbuminuria or albuminuria. So the pathogenesis of renal failure is also explained by the renin angiotensin aldosterone system. So hypertension, heart disease, renal kidney disease, everything is mediated by this renin angiotensin aldosterone system. That is why knowing this system is important. So we finished physiology, we finished the pathology. Now we will discuss about the pharmacological aspects. Now since we know very well about the renin angiotensin system, treating hypertension, treating heart failure and treating kidney disease, targeting renin angiotensin system is important. So just a small recap, I already told you one of the stimulus causing RAS stimulation is beta sympathetic activity. Right, the first beta sympathetic activity apart from hypotension and reduced salt load increases renin activity. So this beta sympathetic activity leads to renin secretion. The next step is angiotensin 2 production. This angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by angiotensin converting enzyme. This angiotensin 2 causes all these effects through a receptor called angiotensin receptor. So and it leads to aldosterone secretion. Aldosterone is produced by aldosterone synthase. So how all can we reduce this dysfunctional RAS system? By giving beta blockers, because beta sympathetic activity begins everything. So beta blockers, now you know, you can very well correlate. Beta blockers like carvedilol, bisoprolol, metoprolol, etc. are used in hypertension, they are used in heart failure, right? So renin can be inhibited. There's a drug called aliskiren, which is a direct renin inhibitor, which is not used clinically. So we'll just remove this one. Then angiotensin 1, I asked you to forget, it's not that important. Angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. So we can inhibit this angiotensin converting enzyme. So that is by angiotensin converting enzyme inhibitors. So any drug which ends with pril, enalapril, captopril, ramipril, perindopril. So anything which ends with pril is an angiotensin converting enzyme inhibitor. So how does this act? Angiotensin converting enzyme inhibitor, when it is inhibited, angiotensin 1 doesn't get converted to angiotensin. So all the 4 activities which I told here does not occur. So BP falls, heart failure reduces, renal dysfunction also reduces. Microalbuminuria also reduces. Now we can target another thing. Suppose even if you leave off this angiotensin converting enzyme, we can reduce the binding of angiotensin 2 to angiotensin receptor. So that is the next class of drugs called angiotensin receptor blockers. We have 2 types of receptors, angiotensin type 1 receptor and type 2 receptor. We are speaking only about type 1 receptor. Type 2 receptor is not found in adults. So angiotensin receptor blocker is angiotensin type 1 receptor blocker. Anything ending with sartan. So our famous telmisartan, candisartan, olmesartan, losartan, valsartan. Okay. So from this graph it is clear that ACE inhibitor and ARB, they act on subsequent steps. So there is no point in combining these two together. So still we see many people writing enalapril and telmisartan together, which is a wrong practice. Okay. Next is aldosterone. I told you aldosterone acts by increasing epithelial sodium channels. So we have some drugs which are aldosterone receptor blockers, like it prevents aldosterone binding to aldosterone receptor. One is spironolactone. Next is eplerenone. And a newer drug which is finrenone. Renin is the latest approved aldosterone antagonist in CKD, especially diabetic kidney disease. Spironolactone and eplerenone are older drugs. We have next category, which is epithelial sodium channel blockers. Just remember the name amiloride and triamterene. So aldosterone is produced by aldosterone synthase. So there's an aldosterone synthase inhibitor also. It is a new drug. Its name baxdrostat. Its name is baxdrostat. It is used in resistant hypertension, because aldosterone excess leads to hypertension, as we discussed. So again, if you remember, beta blockers, ACE inhibitors, ARBs, and aldosterone antagonist, these three drugs are commonly used in one disease, which is heart failure. When ejection fraction is low, we call it as heart failure with reduced ejection fraction. There are 5 pillars of treatment of heart failure with reduced ejection fraction. One is beta blockers. Next is ACE inhibitors or ARBs. Next is ARNIs. Angiotensin receptor blockers and neprilysin inhibitors. To avoid confusion, we'll leave this off now. Next is aldosterone antagonist. And the fifth pillar is SGLT2 inhibitors. So of the 5 pillars, 4 pillars are meant with renin angiotensin aldosterone system. So these drugs are used in hypertension, these drugs are used in heart failure, and these drugs are used in resistant hypertension, and these are used in renal failure. So that's all for today. So we discussed about the physiology of renin angiotensin system, how it acts, and its dysfunction causes these diseases. And we discussed how the pharmacology can be easily understood if we know the simple graph. So we didn't go into the actual details. In further classes or further videos, we may elaborate this further. Thank you.